Hey everyone. So when you're dealing with something like ulcerative colitis, trying to figure out what comes next can feel, well, pretty overwhelming. But having a clear plan, a roadmap, makes all the difference. Today, we're going to cut through all that confusion. We're going to walk through the treatment journey step by step to give you a really straightforward guide to understanding the road ahead.
We'll kick things off by understanding how your diagnosis gets classified. Then, we'll get into the two main goals of treatment. First, getting a flare-up under control, and second, keeping it that way. We'll also explore what the surgical pathway looks like, and then at the end, we'll tie it all together into one clear roadmap for you. Okay, let's dive right in. Before any treatment plan is even considered, there is one absolutely crucial first step: understanding the specifics of your condition. And this isn't just, a formality. This foundation shapes the entire journey that's to come.
Now this slide right here, this is really the starting point for everything. Doctors classify ulcerative colitis into one of three buckets: mild, moderate, or severe. And they do that based on a few key things you see here: how many stools per day, if there's blood, and if you're having other symptoms like a fever. This isn't just some random label. This classification is literally the key that unlocks your specific treatment plan.
And just to make sure we're all on the same page, let's quickly define what ulcerative colitis actually is. At its very core, it's a condition where you get inflammation in the large intestine. Honestly, you can almost think of it like a fire in the gut. So literally every single treatment we're about to talk about has one main mission: put out that fire and let everything heal.
So that brings us to our first major goal: inducing remission. This is the active phase. This is when you're in a flare-up and the entire focus is on calming things down and getting that inflammation under control, like right now.
So, when a mild or a moderate flare kicks off, what's the first tool in the toolbox? Well, the approach is super methodical. It builds step by step, always starting with the most targeted and gentlest options first.
And here you can see that step-by-step process in action. For inflammation that's just in one area, the first move is often a topical medication that's applied right to the source. If that doesn't do the trick after about 4 weeks, then an oral or pill version is added to the mix. And if you're still not in remission, that's when a corticosteroid, a really powerful broad anti-inflammatory, is brought in. It's a very clear, very logical escalation.
You're going to hear this word aminosalicylate a lot. The easiest way to think about it is as a targeted anti-inflammatory just for your gut. It works directly on the lining of the intestine to cool things down, which is exactly why it's so often the starting point for treatment.
Okay, but what if the colitis covers a bigger area of the colon? Well, the strategy is actually very similar, just with a bit more firepower from the get-go. The main difference is that doctors will often start with both the topical and the oral medications at the same time for a more comprehensive initial attack on the inflammation.
But a severe flare, that is a completely different ballgame. This is not something you manage at home. It absolutely requires heading to the hospital for immediate, intensive, around-the-clock care to get the situation under control safely and as quickly as possible.
Once you're in the hospital, the clock is really ticking. The first-line treatment is powerful IV steroids to knock down that inflammation fast. If for some reason steroids aren't an option, another IV drug like cyclosporin can be used. But here's the crucial part. If there's no significant improvement after about 72 hours, the conversation has to shift to considering surgery. This is a really critical decision point.
Okay, so once a flare is finally under control, the job isn't over. I mean, in some ways, it's really just beginning. Let's move on to that second major goal: maintaining that hard-won remission and, preventing future flares from popping up.
Your long-term maintenance plan is totally tied to your history. If you're coming off a mild flare, the strategy is often to just continue with the same kind of medication, that aminosalicylate, but at the lowest possible dose that keeps things quiet. On the other hand, after a severe flare, or if you have a lot of relapses, a stronger approach is usually needed. That often involves drugs that regulate the immune system, called immunomodulators, for better long-term control.
While we're on the topic of maintenance, there are a couple of other interesting points to mention. There's some evidence that probiotics, the good bacteria, might actually help prevent a relapse in some of the milder cases. And then, on the flip side, here's a really important distinction. A drug called methotrexate, which is used in other conditions like Crohn's disease, is generally not recommended for UC. The studies just haven't shown it works, which really highlights how unique each condition is. Now, for some people, medications just don't provide enough control, or maybe they stop working over time. And that's when we turn to the surgical pathway. It's so important to see this not as a last resort and definitely not as a failure of treatment. Think of it as a planned, proactive, and often very effective way forward.
So what are the signposts on this roadmap? What tells you and your doctor that surgery has become the right path to take?
Well, it really comes down to two main scenarios. The most common is simply when medical therapy, even the strongest options, just isn't keeping the disease under control. The other reason is an emergency, like if the colon gets a tear or a hole, what's called a perforation, where surgery becomes urgent and can be life-saving.
Okay, before we compare the surgical options, we have to get our heads around one key term: ileostomy. This is a surgically created opening on the abdomen that lets waste exit the body into a special bag. And the most crucial detail here is that an ileostomy can be either temporary or permanent, and that's the main difference between the procedures we're about to look at.
And here are the two main options, side by side. The preferred approach for many is called an IPAA, or a J-pouch surgery. With this one, the colon is removed, but the surgeon creates an internal pouch that acts like a new rectum. This means you need a temporary ileostomy while that pouch heals. In contrast, a complete panproctocolectomy removes everything, the colon and the rectum, which results in a permanent ileostomy. This distinction is probably the single most important factor to understand and discuss with your team.
So we have covered a ton of ground here, from the initial diagnosis all the way through treatment and surgery. Let's bring it all together and just quickly summarize the key takeaways that really form your personal treatment roadmap.
So, what are the big things to remember? First, severity is key. It's the compass that guides everything else. Second, the first goal is always to put out the fire of a flare, using that clear, stepped approach. Third, the long-term goal is all about keeping the peace, with a maintenance plan that makes sense for your disease history. And finally, remember, surgery isn't a dead end. It's a valid and really effective pathway for a lot of people.
This roadmap gives us a pretty clear picture of how treatment works today, but it does leave us with a really important question for the future. As our understanding of ulcerative colitis gets deeper and this brand new, more targeted therapies are developed, how is this map going to change? How might it evolve to offer even more personalized and effective pathways for every single patient?